hypotension and circulatory insufficiency.
Uh-huh.
And it's very clearly stated hypotension is a number.
Yeah.
Circulatory insufficiency is very difficult to define, and you have all this discussion we have here. And the indication for doing something, that's when you think you have a circulatory insufficiency.
Yeah.
So, and you have to make up your mind as a clinician, and this is obviously difficult.
Interesting. So you see, guys, we can't even agree on the words, and then how to treat them. That's interesting, though. Thank you for the comments. All right, let's get to the vasopressor, inotrope, and Lusitropes thing. This would be a presentation that I would, if we had 3 hours, I could go through in more details. We don't have 3 hours. We have 50 minutes. And who can define the vasopressor for me? Anyone? Vasopressor? What's a vasopressor? Who can tell me a pure vasopressor, the name of a vasopressor? Well, you have to be able to define vasopressor to be able to tell me the name of vasopressor. Who can define inotrope? No, just define it first. Inotrope. Increases contractility and cardiac output. Very good. That's an inotrope. Who can define a vasopressor? Increases blood pressure by inducing vasoconstriction in periphery. Okay. Who can define a vasopressor inotrope? That does both. Yeah, very good. Who can define a Lusitrope? Who can define a Lusitrope? Increases contractility. Oh, and vasodilation. So peripheral vasodilation decreases the resistance against which, for instance, the heart has to pump. Very good. What is the difference between SVR and afterload? Difference between SVR and afterload. Okay, Martin, could you talk about this a little bit when you talk now? Okay. Anyway, so good. So there are, well, you don't see that. I'm going to try to talk about volume as well. A vasopressor inotrope dopamine, a vasopressor inotrope epinephrine, a primarily inotrope dobutamine, and a Lusitrope myrinone. It's tricky, actually, this myrinone thing. Norepinephrine and the vasopressor, you can see it there, but I'm not going to talk about it. I hope I can cover it. I may not be able to do so. Shahab and I just published a paper on this in Clinics in Perinatology. I would like to suggest that you might want to read it. It has a lot of the basic cellular mechanisms as well that I am not going to be able to touch on, okay? It was published last month or whenever, okay? All right. So volume. Who uses saline primarily? Okay. Who uses albumin primarily? And the rest of you guys, you don't use anything. Good. Okay, volume is done. We talked about it. Why are you using saline, not albumin? Cheaper. Yes, good. Cheaper. Coming from the United States is an important point, obviously. Cheaper. What else? All right, let me show you what. Is as efficient as albumin. Yes. And albumin might have some interesting effects that, according to the studies 10 years ago, discredited the use of albumin significantly. However, and there is a however. I show you 2 studies, okay? This is a study that was done in the more than 10 years ago, looking at albumin 5% in 32 patients during the first postnatal day, and looking at saline. I shouldn't say normal saline, because there's nothing normal about saline, as we discussed that this is an unbalanced solution. But using saline, and the blue are the saline lines, the purple are the the purple dots represent albumin, and here you have mean blood pressure on the y-axis and postnatal hours on the x-axis, and here you have a ventilatory index on the y-axis. It appears to be that indeed saline, and many studies have repeatedly shown this, is as effective as 5% albumin. There was a study done in England well, at least 15, 20 years ago, looking at delivering saline, 5% albumin, and 20% albumin. But 20% albumin delivered the same amount of albumin, 1 gram per kilogram, so with lower volume. And they found that the administration of the volume was important for increasing blood pressure, not the albumin administration in that study. And Greeno published that study way back. Anyway, also there's a little suggestion here that you may have a little bit of an impairment in your oxygenation when you give albumin. It didn't reach statistical significance. In 1978, a study suggested that when you give albumin, then you will significantly increase the potential for pulmonary edema. And there are some other studies that suggested this over and over and over again. You may also induce shifts in terms of intracellular and extracellular compartment regarding water shift. And it may not be good for the brain and all these speculations. And so we decided that saline would be the better way to go. It's cheaper, it's non-infectious, et cetera, et cetera, et cetera. And this is a study that confirms those findings. However, in 2008, and there was the largest study published on this subject with 49 patients receiving albumin, 52 patients receiving saline. And what they found that saline was more effective, albumin was more effective in increasing blood pressure, the degree of blood pressure improvement, the duration of normal blood pressure, and the percent of infants who receive dopamine. Oops. Now, this is a pretty good study from this standpoint. The problem with the study is when you look at the IVH data. So this study enrolled 25 babies that were less than 1,500 grams out of the 49 in the albumin group, and 31 babies out of the 52 saline groups. So there's a subgroup of less than 1,500 grammars. And when they did the analysis, what they found that all IVH in the less than 1,500 grammars, so 25 and 31, it was 28% in the albumin group and 45% in the saline group. Now, 45% of IVH in less than 1,500 grammars, there is something wrong. There is something wrong, okay? And then you look at the grade 3 and 4 IVH, 8% in the albumin group out of 25 patients, 2 had severe IVH, and 7 out of the 31, 23% had very severe IVH. There is something not right here. So I don't understand what was going on here, and they said, they acknowledged that this is probably a statistical fluke, but they couldn't address the question, how come that you had a very high underlying IVH? So again, now we are back to the square one. Someone should do a study. a study that is really well controlled. All right, I leave you with the volume here, and I'm going to show you some data. And this projects decently. This is just one set of data from our comprehensive monitoring system, okay? This is here, you have time, and these are the different parameters. This is this is cardiac output, continuously monitored beat to beat, non-invasively. This is stroke volume. This is heart rate. This is here calculated vascular resistance by the computer, oxygen saturation, muscle, kidney, brain, regional tissue oxygen saturation, mean blood pressure, and there's also a systolic and diastolic blood pressure, but you don't see it on this thing. And there is TCOMs, CO2, transcutaneous CO2, and respiration. In a who actually was treated by the team and was being monitored. And the baby had a drop in the blood pressure, 10 points or so, but still wasn't really hypotensive. But the team looked at the baby and said, well, this baby is poorly perfused, the blood pressure started dropping, let's give the baby a saline bolus. And unfortunately, you don't see it well, but here, starting at 10 minutes to 15 minutes up to here, the saline bolus was given. And then, you know, they left, they did their stuff, whatever, and we were monitoring this patient. Look what happened. The saline bolus was associated with an increase in stroke volume, decrease in heart rate, and then a trend of an increase in cardiac output. So you actually increased preload. Okay. The whole thing lasted for 10 minutes after the transfusion, after the infusion. Exactly the same thing what yesterday Gorm showed. Remember those peaks, those 2 peaks? And then things came back to the previous values. No effect on tissue oxygen saturation. You asked this question. Brain, muscle, kidney, everything remained the same. And blood pressure, a couple of minutes after the discontinuation of the infusion, for some reason, and I do not see any relationship with treatment, increased again and went back to close to baseline. So when the team came back 40 minutes later, they said, see, it worked. But it didn't. It's totally independent. But there is, for instance, a really cool evidence. If you give volume, it's going to last for, the impact on cardiac output is going to last for probably 30 minutes. Now, Gorm has a study, and I will show it, that was published in 2000. They found that 2-hour window for the increase. But it's transient, okay? You guys also did some studies, but never published them. Yeah. So it was, yes?
Can you show the slide?
Sure. $5.
What about the cerebral original oxygen saturation? It decreases and then...
So the blood pressure goes down here a little bit, and the CBF appears to be decreasing a couple of points indeed. And as blood pressure goes up, it might or might not go back. So that's a good point, but I didn't want to take this sort of leap that this kid wasn't stable completely and might have had a little bit of a pressure dependency indeed, because arterial oxygen saturation did not change. So that's a good point. I just didn't want to speculate. But you're right. This is something that we need to take into consideration. But, oops, something happened here. Yes. So, yes. No, but what I'm trying to tell you, tomorrow we're going to talk about this. If you can see what is happening second by second, we download this information from how sharp, how fast, 0.1 to 3 hertz, depending on the equipment. I mean, pretty fast. And everything is integrated into one collection system. But anyway, you're right. But is this clinically significant or relevant? This is physiologically interesting. But we don't. So you're right. So, and this is, I do believe, guys, that, and I'm happy to provide you with this equipment if you want to, and do some studies with it. I'm serious about it. It's not very expensive. Other than you have to pay me $1 million, but no, it's pretty interesting. You can do this anyway. Medications, cardiovascular medications, basic stuff, only the basic stuff. Here now, let's switch. Okay, volume is gone, everything else is gone. Cardiovascular actions of adrenergic and vascular vasopressin receptors. These are the receptors here, okay? And this is where they are located. Okay, this is in this paper that I talked to you about. So, alpha receptors in the vasculature, if you stimulate them, you will actually significantly increase, with the alpha-1 receptors, induced vasoconstriction. Alpha-2 receptor stimulation will cause arterial vasodilation and venous vasoconstriction. But you have primary alpha-1 receptors in the arterial system. You remember also that 75% of the circulating blood volume at any time point is on your venous side of circulation. You remember that as well. Okay, 75% approximately. So stimulation of cardiac alpha receptors will increase inotropy. Okay? Beta 2 receptors, vasodilation, beta 2 receptors in the heart and beta 1 receptors, significant increase in inotropy, significant increase in chronotropy, and increase in conduction velocity. So the heart is going to pump faster, better, like crazy. Okay, good. Dopamine is a promiscuous hormone, and the dopamine receptors do a lot of things. They cause vasodilation in the vessels where they are expressed. Kidneys, mesenterium, coronary arteries, and a little bit in the pulmonary arteries and also in the vessels of the neck. Okay? Here you go. Renal, mesenteric, coronary circulation, pulmonary circulation, and extracranial vessels. So it's vasodilation. Dopamine receptors are also expressed on the myocardium, and they cause some increase in inotropy. And then the vasopressin receptor, the 1A, causes significant vasoconstriction primarily. So this is how you have to think when you give your medication. So if you give dobutamine, who can tell me what it does? You give dobutamine now. What receptor types get stimulated by dobutamine? Beta. So you do this. Okay. What about this? I will show you. I will show you right now because this is cool. I have to show it right now because I may never get there. The way how you guys ask me questions. Okay. So here we are. Dobutamine. Dobutamine is here. And I will come back to this. So this is what dobutamine does, and this is a tricky drug, okay, a tricky drug. And this is also in this paper. So dobutamine, when you buy it in a vial, if you look at the vial closely, you can see that half of the molecules are waving with their left hand, the other half with their right hand. So they are 50% isomers, enantiomers. 50% left-handed, 50% right-handed molecules. The left-handed dobutamine is an alpha-1 agonist. Oops. Increases force of contractions in the heart and increases vascular tone. All right? The right-handed dobutamine is a pure beta receptor agonist like isoprenaline. It increases force, increases rate, decreases tone. So you have now an increase in the force, but you have an effect canceling out, basically, depending on the expression of the different receptors in the different systems, okay, and also their downregulation. Oops, but there is a problem, guys. One of the metabolites of dobutamine, this right-handed 3-orthomethyl-dobutamine, has a significant alpha-1 receptor antagonist activity. So now you have decreased force a little bit, but also decreased tone. And so when you buy the dobutamine and you look at the vial, remember, go back and look at it. You will stimulate alpha-1, beta-1, and beta-2 receptors. You will inhibit alpha-1 receptors. And in the end, you get a very good inotrope. And vascular tone will decrease in patients that have a higher level of beta receptor expression. And preterm neonates, because there's a developmental regulation of beta receptor expression compared to the alpha receptor expression, alpha receptors are expressed during early development at higher density. So in preterm neonates, it may or may not cause a decrease in the SVR. It could, but it doesn't cause an increase in the SVR. So it's not a vasopressor. It's probably a mild vasodilator. In term neonates, it has a more of an effect on vascular resistance because there are more beta receptor expressed, provided that no significant receptor downregulation has occurred. And when I talk tomorrow about hydrocortisone, I will address this issue. Just remember when we get back to this, that this is a very important point for you to figure out how dobutamine works. The major issue is that dobutamine is a fantastic inotrope, The problem is when you give it in cases where there is, for instance, a little bit of a myocardial hypertrophy, or you give it to a patient who doesn't necessarily need it, you will compromise diastolic function and filling. I did it once. Unfortunately, I don't have the tracing, but and perfusion dropped out of the sky because I increased the dobutamine. The kid had initially compromised myocardial function, then got better, but I wanted to have better flow. I went up on the dobutamine, and then we were doing the echo, and then you could see that there was less filling on the left side. And then when we dialed down back the dobutamine a little bit, 2 minutes later, the whole thing was back again to normal. It's very important. So it's anyway. So this is dobutamine. So it's not as simple as you thought. So it has direct receptor stimulatory effects, and its metabolite inhibits alpha receptors. Okay, alpha 1 receptors. All right, good. So let me get back to where we were before. And this is just an overview that you guys probably should really understand and remember. So when I ask you, give me please a pure example of a vasopressor. So what is a vasopressor? A phenylephrine. Phenylephrine has very little to no effect on cardiac output and is a pure vasoconstrictor. That's phenylephrine. Epinephrine is probably the best vasopressor inotrope in the sense that it also increases significantly myocardial activity. We're going to talk about it. Norepinephrine has very little beta-2 receptor effects, and this is why it's less of a vasodilator, so it may actually compromise cardiac function if you use norepinephrine in situations where vascular resistance is not significantly decreased. In the pediatric intensive care units, norepinephrine is the primary drug of choice in septic shock. That's the best drug because it really addresses the first issue of vasodilation and the second issue of potentially compromised myocardial function. Okay? We don't necessarily use it, and there are only 2 studies in abstract forms available in preterm neonates, and 1 study looking at PPH and in term neonates. Okay, good. And then it's dopamine with all those things, and the dobutamine we talked about, isopropyl we don't use anymore, vasopressin. Have you guys been using vasopressin? We actually wanted to do a study. And in the first 3 patients, we'd done it like 8 years ago. The first 3 patients, maybe we used higher, remember Shahab? Maybe we used higher dose than, they stopped peeing. So we just let it go. Yes?
There's a Japanese study, I think it's about 20 babies of 24 weeks with persistent hypotension, where they used vasopressin or terlipressin. In a very carefully titrated dose, they were being better after taking it, and it had a survival rate of 50%. Which I thought was quite incredible because, I mean, you could say you have a baby of 24 weeks with a vasopressor system, and they're given everything you were talking about, and then they were progressing to terlipressin.
Interesting. So anyway, I'm not going to talk about it. I have mechanisms and some data in adults and cardiac patients as well. I was not aware of this study, but I'm going to look it up. I will have to do that. And then milrinone, amrinone, phosphodiesterase inhibitors, and phosphodiesterase 5 inhibitors, sildenafil, and the rest of the jazz. Now, all these medications, and this is, if nothing else, if you guys remember this, you will go home and you will clearly understand what to do. Okay? So this is the only slide you need to remember. So because, as I told you already, adrenergic receptors, the expression of these receptors is regulated developmentally, your preterm baby will be prone, as long as downregulation of the receptors hasn't occurred, to more vasoconstriction. So higher doses or medium dose of dopamine norepinephrine will vasoconstrict these babies, and that's not good. This is where you should start low if you start it, and titrate very carefully. Preterm babies. Term babies, because they have more beta receptors expressed, they are not as sensitive to the vasoconstrictive effects of the vasopressor inotropes. Downregulation of the receptors. Do you guys know what it is? All right, so tomorrow we're going to cover this. This is a very important topic. Who has been using hydrocortisone in vasopressor-resistant hypotension? And you don't know what receptor downregulation is. Shame on you. No, really, because when you use a medication, you should. I mean, the reason why I did go into neonatology, because there were 5 medications that we used to use. I don't remember 3 of them, but whatever it was. But if you use them, then you understand the mechanism of action, you understand the side effects, and you may understand the response when it's different from what you expect, why it might have happened in that baby. I forgot the shame on you, I was joking. Anyway, so this is one issue. And then there is this issue with the myocardial development, which is very important. So, what is the most important lab study that you will do before you start any inotrope or vasopressor? This is a study in the lab that your lab is going to be able to do it for you in a neonate. Yeah, well, I heard it. I heard it. Calcium? Yeah. So you will check ionized calcium levels. Why? Because the neonatal heart has a limited capacity to mobilize calcium from the limited intracellular stores. And it depends on, for its activity, also the vascular system, on the availability of extracellular calcium. And if your calcium is low, you can give whatever you want to give. It ain't going to work. So please remember that you ensure that in your sick patient, you have a calcium level, and that I can tell you for sure. I can't define hypotension for you, but this thing I can tell you. You really should check serum calcium levels. And you can do it now with the gases. They give you the ionized calcium, and then you can. So please don't forget that. And then there is this dysregulated release of vasodilators when there is oxidative stress or infection, especially nitric oxide and prostaglandins. And also there are hormones that run totally wild, and they will affect and influence how the entire system works. What would be the best medication to give if you have an increased dysregulated nitric oxide release like in septic shock? What is an inhibitor of nitric oxide synthase? Methylene blue. If you gave methylene blue, if the baby's blood pressure were 5 in septic shock, it would go up to 50, I bet. The problem with this is that you also inhibit nitric oxide production in areas where you should have them. Brain, myocardium. So you vasoconstrict your brain and your myocardium as well. And this would lead, and people, actually there was a suggestion to give methylene blue to babies with septic shock. And animal studies showed that this is a very bad idea. Okay, good. Okay, dopamine. Jesus, we can do this misquote here. So dopamine is a complex thing, and it does a lot of things and beyond that, okay? And I spent 8 years in the lab to try to figure out how sodium potassium ATPase is regulated. Actually, I came across this finding, and this was and I'm old enough to proudly to say that, yeah, I came across this finding from clinical studies. We proved it. Then we started working together with someone also in the United States to look at the phosphorylation pattern. And that person who helped us, and not only because of this, got the Nobel Prize in 2000, and our work was mentioned during the Nobel Prize speech. And so, and all these things came from the observation that when I gave low-dose dopamine to the neonates, GFR went up by 15% only, but renal sodium excretion increased by 40 to 60%. So then I figured there must have been a direct tubular effect, and this is when I went to the Karolinska Institute and started working on this. I'm proud of it now. I didn't talk about this because I thought I would be not modest if I don't do it, but I think I can do it now because who cares? Anyway, so spent a lot of time on this, and but having said that, it's a complex system, and I don't have time to talk about it. But what I would like to make sure that you guys remember is the following. At very low doses, dopamine also stimulates already the receptors in the renal and mesenteric and coronary arteries. And it induces vasodilation in the kidneys and the intestine, and this has been shown in neonates. Increases GFR, has direct tubular effects, has a positive inotropic effect through the dopamine receptors. Actually, it increases lung fluid clearance. Please read the study, blah, blah, where is it? I don't know. Read Bertorello, A. Bertorello. Look it up. It's cool. It's very interesting. It's upregulation of expressed sodium potassium ATPase molecules in the lung epithelium. It's very interesting, but we don't know if it has any clinical relevance. It has a lot of endocrine effects. So who uses dopamine sometimes more or less in first couple of days when the babies are sick? Yeah, a couple of you. Yeah, I'm sorry. What do you guys do? When do you guys send the neonatal screen? Do you send it when the baby is on dopamine? The newborn screen. When do you send it? Normally. A 28-weeker comes to your unit, is hypotensive, looks bad, you started dopamine. It's 2 hours old. When do you send your neonatal screen? 10 days of life. Okay, good. Anyway, the major issue is dopamine significantly inhibits TSH secretion and prolactin as well, and growth hormone as well, because dopamine 2 receptors regulate those hormones. Do not send a neonatal screen if the baby is on dopamine, because you will suppress TSH, and babies that might have congenital hypothyroidism, and the diagnosis of that is TSH is sky high, you actually may blunt this response, and you may not realize that this baby has congenital hypothyroidism, okay? So this is why you need to know about the endocrine effects. Oh, you can do it and repeat it, but make sure that you repeat it. Yes, make sure that you know about this. Yes, very good. Alpha receptor stimulation at higher doses. At 4 mics, you already have alpha receptor stimulated, guys, significantly in preterm neonates. Vasoconstriction, some positive inotropic effect, and beta receptors, you then run the heart. For the inotropic effects of dopamine, please remember that 50% of the effects of dopamine on increasing myocardial contractility comes from release of stored norepinephrine in the myocardium. So only 50% is direct stimulation, and 50% is secondarily to increased norepinephrine release. And the problem is that in preterm neonates, you actually, these stores get pretty fast exhausted. So within 4 to 8 hours, you will see a decline in the myocardial effects of dopamine because you have no norepinephrine anymore. So if you have a patient who is in late septic shock with vasodilation and poor myocardial function, then epinephrine would be a much better drug to use. Or you could add dobutamine to dopamine that many of people do. But anyway, just remember that, okay? Okay, what's the highest dose of dopamine that you have used in your life? 20. 100. 250. 300. Any more? 500. No? So why 20? Where are the data coming from, ladies and gentlemen? Come on, why 20? Because, so this is why you are using 20. Here it is. So you are using 20 because if you are treating healthy adults, in healthy adults, 20 mics of dopamine has the maximum vascular response. And when you are treating your sick patients with downregulated receptors, abnormal local vasodilation, and all the rest of the jazz, you are only doing 20 because you think you are treating healthy adults. That's what it is. And then you reach 20 of dopamine, and you go, okay, so the kid is still hypotensive, put the perfusion on, I'm going to add epinephrine. What are you really doing? You are just stimulating the alpha receptors more than you would stimulate with higher dose of dopamine. Now with epinephrine, the same thing. And if you argue that I don't want to give high dose dopamine because then the hormonal effects are really significant, I have bad news. at 0.5 mics per kilo per minute, you have maximum hormonal effects. So if it's, no, I'm not telling you to give 100 mics of dopamine, don't misunderstand me. I just want to make sure that you need to understand there's no data what the dose of a vasopressor should be, because it's not the pharmacokinetics that really matters, it's pharmacodynamics. In other words, the response. Whatever you want to achieve, increase blood pressure in appropriate cases. Now, if you give vasopressors in a situation when the myocardium is not functioning well, you increase basically induce vasoconstriction, increase SVR, increase afterload, you're going to poop out the heart, and systemic perfusion is going to drop. And you may have a good blood pressure, but the kid is going to look like poo-poo. So what it means that you are not giving the right medication or the right dose. So here you go. Look at this. This was done in Italy. When in hospital, there were people running around, and they fetched a couple of them, and they decided to do a study on them, looking at dopamine 1 receptor stimulation by assessing renal blood flow, beta 1 receptor stimulation by cardiac index and heart rate, and alpha receptor stimulation by calculating systemic vascular resistance index and looking at arterial blood pressure. At 0.5 to 4 mics, maximum renal vasodilation occurred. This is where the renal dose of dopamine comes from. Okay? Then beta receptor stimulation occurred with increase in cardiac index, cardiac output, from 4, I would say, to 12, whatever. And beyond 10, they start to see an increase in blood pressure and vascular resistance. So that's in adults. Now in neonates, please remember, alpha receptors are expressed more. So neonates actually, preterms, you stimulate alpha receptors before the beta receptors more significantly. But this is it. So at 20, they maximize the effect. And now you are treating your preterm neonate that has nothing to do with a healthy adult. You're telling me that I'm stopping at 20. And then I'm going to add norepinephrine, epinephrine. I don't care what you do, just at least in terms of, you add epinephrine, is fantastic, good for you, God bless you. But then don't give dopamine. Why the heck are you giving two medications that they do very similar things, not the same, but from a cardiovascular standpoint, they are very similar, yet they have different profiles, obviously, okay? And I don't have time, obviously, to go into showing you the data on our animal studies we published last year in pediatric research. You might, if you Google my, not Google, Google my name, you have some, don't Google my name. But if you go into PubMed and you punch my name in, you will find the study last year on developing piglets. It's very interesting. Read it. It gives you a little bit of information. Anyway, yes?
Yeah. And this renal vasodilator effect is true in preterms, or is true? You can trust it?
You can. Okay, so I won't have time for this, but this is, by the way, when they gave higher dose. I'm coming back to this is when they gave higher dose of dopamine. Okay, so dopamine. The pink is 5 to 20 mics. Your dopamine. And then this is Johns Hopkins dopamine, 26 to 250. Blood pressure only increased with a very high dose, but urine output increased with a very high dose, suggesting that instead of vasoconstricting the kidneys, in these kids that had significant vasodilation and receptor downregulation, you had to give this much to start reaching the few receptors that have been expressed. That's it. Anyway, I'm not telling you that you start at 250, okay? Please don't misunderstand me. Just understand it that you may use. This is the pulmonary effect that you talked about. Interestingly, this is only one sentence. It appears to be that under circumstances when the pulmonary circulation, vascular bed, has been exposed to increased flow, you upregulate, as a defense mechanism, vasoconstrictive hormones and pathways. So you upregulate alpha-1 receptor expression in the pulmonary arteries. You upregulate endothelin-1 production. And in these patients, when you give them dopamine, you also will cause a more enhanced vasoconstriction. So your babies with a hemodynamically significant PDA will actually, because before this study was published in 2008, I would have said a baby with a hemodynamically significant PDA and poor perfusion, don't give dopamine because you're probably going to increase vascular resistance. The myocardium is pumping anyway like crazy, and you're going to shove more blood into the lungs because pulmonary vascular resistance otherwise has not been shown to be increased by dopamine out of proportion of the increase in systemic vascular resistance. That ain't the case. It appears to be, and I don't want to get into it, but SVC flow was improved a little bit, and pulmonary vascular resistance went up when they gave dopamine, so suggestive of decreasing shunt from left to right. That was it. So it's very interesting. But again, animal studies have shown that when you expose the vascular bed to high flow, you change the pattern of receptor expression and local regulation of vasoconstrictive substances, okay? So that's an important point. This is just cardiac output. This is Gorm studies. This is cardiac output increases. Cyril, I'm not going to get into this. We were talking about renal, weren't we? So this is the renal study, one of the studies, and then there is now several studies that have shown the same thing. This is way back from 1998. This is urine output. Babies were put on dopamine. Most of them were in between 2 to 10. First postnatal day. Urine output in most of them went up. Some of them did not. But look at the renal artery PI, significantly decreased, suggesting vasodilation in the kidneys. And you can see, unfortunately, those lies, but in all patients, we had a decrease in the PI, suggesting that all patients vasodilated. And we repeated this with indomethacin. I didn't put it in there. And interestingly, we found the same thing, that even indomethacin pretreatment did not prevent this effect. But there is no evidence that when you have indomethacin on board and you have a decrease in urine output, that dopamine will really increase urine output or not. There are conflicting data, and I don't have time to go into that. And this is just what happens in the kidney. Forget it. I'm not going to get into it. I would like to just summarize for you what dopamine does, and then I will show you one more slide, and then I'm going to be done. And it's pretty complex because dopamine, the only side outside the central nervous system is the kidney where dopamine is being produced. And dopamine plays an important modulatory role in regulating sodium excretion. So let me tell you one thing. And it's via dopamine 1 receptors. These receptors have normal function, and then you will actually pee out more sodium. So in the United States, there is an interesting subpopulation of essential hypertensive patients beyond 45 to 50 years of age. The black Americans have a high proportion of essential hypertension. And now it has been shown that in many of them, the dopamine 1 receptor is mutated in the kidney. So they actually reabsorb the sodium during their life at a higher rate, so they probably reset their total body sodium at a different level than you would do or I would do. And this will lead, in the long run, to a significant renin-angiotensin-induced hypertension. Okay? Now, why is this? I think when you live in Africa, and you have lived there for 20, 30, whatever, how many thousand years, then you will benefit if you actually can reabsorb more sodium because you sweat most of the time. And you will become less dehydrated. So this might have been a survival advantage under those circumstances. And it didn't matter 20,000 years ago, beyond 30, 40 years, that you would have developed hypertension because you never reached that age. But now you pay for it. We never have anything. There is nothing free, guys. Anyway. So this is it. So this is what dopamine does to you and to me. It increases blood pressure by increasing systemic vascular resistance and cardiac output. But there is an interplay, and if you increase systemic vascular resistance too much in an immature myocardium, you might compromise blood flow. You have to be very careful. Same thing goes for epinephrine, but epinephrine is a better inotrope. Organ blood flow. CBF only increases when the babies are hypotensive. Non-hypotensive neonates, medium dose dopamine doesn't appear to increase CBF. SVC, there was one study only that Martin referred to, did not increase SVC flow dopamine, but they didn't titrate the medication. That was a nested study in an indomethacin trial. something like that, and they gave 10 and then 20. So they didn't titrate it, so there might have been some threshold that they overstepped, so that was basically it, and so that needs to be seen. Mesenteric effect is variable. In some patients, there is vasodilation. If you give it inappropriately high doses, you may vasoconstrict them. And that study, I must tell you about that study. That was crazy. Let me tell you about this study. Just, I can't hold myself. Like, this is so cool. It's really cool. This is the study. It's a great study, actually. It's a great study. Oops. Oops. What happened to me? So it's a really interesting study. The total number of patients involved is 14. 10 babies responded to dopamine with no change or an increase in LVO, mean blood pressure, no change in SVR. 4 babies, to higher doses, they responded with a relative decrease, but it was like 10% of the LVO or 15%, an increase in the mean blood pressure, and an increase in the calculated SVR because of this. And then for the mesenteric artery, these patients that appeared to be vasoconstricting more, they had decreased evidence of vasoconstriction and mesenteric circulation. This is all cool. The way how it was presented is that all the data were presented as baseline, change from baseline, okay, except for this cardiac output data, because this was not significant. So what they did, they compared this decrease to this increase. That became significant. But that's all right. So don't be influenced by your data. The more important problem was that in the abstract read that in 10 patients, blood pressure and mesenteric blood flow increased. In 40 patients, blood pressure and mesenteric blood flow, or cardiac output and mesenteric blood flow decreased. And then someone wrote an editorial based on having read the abstract only, that because of the significant evidence now that dopamine decreases cardiac output, should not be used, blah, 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 blah. Well, if you write an editorial, take the time to read the paper. So anyway, and yes, if you give higher doses of these things, you may actually run into problems, so you have to be very careful. So this is why modulation is important. Last slide, I swear. Okay, so I'm not going to talk about, I told you epinephrine is a cool drug. It's very good, but remember that when you give epinephrine, lactate levels will increase independently, okay? The baby gets better, but if you follow lactate levels and the kid is on epinephrine, you have to understand that the lactate is going to go up because of the independent effect of increased glucogenolysis. And lactate is produced in the meantime and then is shuffled back. But you will see the increased lactate. So make sure that you guys take care of this and understand it. And you may be in a bind here because you don't know, is the kid getting better? And lactate increases because it's a kid of epinephrine, because the epinephrine's effect on glucogenolysis? Or is this because the baby's not getting better and the lactate is going up? So just make sure that you know. Now, the only on the last slide I'm going to show you is a mechanism. PPHN, we talked about PPHN. We talked about nitric oxide and sildenafil, okay? And milrinone, okay? I show you something that I believe it's going to help you to understand how to deal with these two medications, okay? I'm talking about milrinone, phosphodiesterase 3 inhibitor primarily, and sildenafil. So this is the mechanism by which beta-adrenergic receptor stimulation or prostacyclins, by stimulating adenylate cyclase, increasing cyclic AMP, will cause smooth muscle relaxation, okay? So if you give isoprel as pure beta receptor agonist, you upregulate adenylate cyclase, you produce more cyclic AMP, you have muscle relaxation. Phosphodiesterase 3 is the enzyme that chews up your cyclic AMP and produces 5 AMP. It's uncycled. Okay, that's it. Good. When you give nitric oxide, what you do is you stimulate soluble guanylate cyclase activity. You produce more cyclic GMP. You cause smooth muscle relaxation by decreasing calcium entry into the cell and by complex mechanisms, and you cause vasodilation. Okay? Good. So giving the two things, if beta receptor stimulation, nitric oxide, they all vasodilate. And phosphodiesterase 5 is the enzyme that chews up your cyclic GMP and produces the uncycled molecule. Okay? All right. In us, cyclic GMP, and cyclic GMP is a very important molecule. I told you yesterday that this is a messenger that's also linked, when it's enhanced, increased locally during development, to increased lung development, both parenchymal and vascular development, okay? But anyway, in us, cyclic GMP will actually inhibit phosphodiesterase 3 expression and function, and you will have even more cyclic AMP, so you have a little bit of a shift also towards cyclic AMP-induced vasodilation in your lungs. This is what we do. We all do it. When you give nitric oxide and you ventilate with 100% oxygen in your patients, you do the opposite. You upregulate phosphodiesterase 3, then you decrease cyclic AMP, and you take away the cyclic AMP-associated vasodilation in your lungs. So in these patients, giving mirrinone would actually be really effective by decreasing pulmonary vascular resistance further, because you prevent the upregulation of phosphodiesterase 3 by your management giving nitric oxide and mirrinone. And sildenafil, inhibiting phosphodiesterase 5 primarily, will increase your cyclic GMP. So this is why when a patient does not respond well to nitric oxide, giving mirrinone first and potentially sildenafil makes physiological sense or pathophysiological sense. Whether or not I can recommend it, obviously there is no data for outcome and clinically relevant measures. And that was, I'm not going to show this study. That was the last slide I swore. The only slide that I'm not going to show you, I'm going to tell you one thing. Since phosphodiesterase 4 is the intrauterine enzyme in the myocardium that metabolizes cyclic AMP, primarily in the very first few days of postnatal life, mirrinone may have less of an effect as an inotrope. It has been shown in animals. Because you inhibit phosphodiesterase 3 primarily, that doesn't play a significant role yet. It takes, in animal models, 5 to 7 days to upregulate phosphodiesterase 3 and downregulate phosphodiesterase 4. And now when you give mirrinone, you will have a positive inotropic effect. Okay? I think this is one of the reasons you guys may not have seen an effect. I am done, and I thought when I go down to this number of very few slides, you guys will be happy. All right. Let me ask you a question, guys. We have 10 minutes to discuss. 10 minutes. 10 minutes. Please ask me questions. Ask me how am I doing.
Is there any? But is there any price to pay in the systemic resistance when I use sildenafil and mirrinone? You showed the pulmonary action, but what about the systemic action, the vasodilatation?
I show it to you. If I find it.
Because nitric oxide only acts in. Because inhaled nitric oxide only acts in the lung, and the others.
Well, it's not really.
We don't know.
I actually took a slide out that you're asking the question, so let me just show it to you right now. So guys, the question was, what? The question was, and the question is, if I find a stupid thing, Porto, what was it? Vasopressors. Yes, here it is. Patrick McNamara did a study. What was there? Shahab, could you in the meantime answer the question in part by telling your findings in the 7 or 9 or how many neonates with rebound pulmonary hypertension? Oh, we use sildenafil in that. Sorry, yeah. Okay, forget it. Oh, that was sildenafil. Just one sec. Forget it. Here it is. I found it. So the question is, do we pay a price if we give phosphodiesterase 5 or phosphodiesterase 3 inhibitors because we actually might have an impact also on the vascular resistance? We may decrease systemic vascular resistance and blood pressure may fall. There are two things that we need to take into consideration. First, when you have pulmonary hypertension, okay, and there is vasoconstriction and decreased flow, you upregulate defensively the vasodilatory mechanisms. So you will enhance the vasodilatory response to medications in the pulmonary circulation. Nitric oxide does have a little bit of an effect on the peripheral circulation, even when you give it inhaled, although this effect is minimal. But peripheral perfusion, for instance, microcirculation is different. The studies did not show a significant change in blood pressure when you use nitric oxide at 20 mics per kilo per minute because it's bound to hemoglobin, okay? Now, when you give milrinone will inhibit phosphodiesterase 3, but primarily at places where it's upregulated. I showed you that it gets upregulated in the lungs. It is not upregulated in the peripheral vessels. So, in the study that Patrick did, he found the following. This is milrinone. This is OI, and this is time. And they started milrinone here after nitric oxide didn't show some significant effect. And you see the nice drop in OI over the next 60 minutes. And this is the finding for blood pressure. They could not find, except for an initial decrease when they gave the bolus, a decrease in blood pressure. We do not give boluses, actually. And if you want to look at the studies that looked at milrinone and the dose of milrinone in preterm neonates, Martin's group actually has the only data looking at pharmacokinetics in preterm neonates, and that data, Mary Paradis' study that I didn't show because we didn't have time, they did a very interesting preliminary study just to look at pharmacokinetics, and they found that you have to modify, or you should probably consider modifying, should I say that, the priming dose for milrinone if you give it. We do not use prime. Shahab, do we use prime? No, we don't use the bolus. We just give, but we go up with milrinone. From 0.2 we go up to 0.8. I went up to 1. Titrating it and then making sure that the baby's perfusion is the same and monitoring the patient. But always titrate it. Don't start at 5 or 0.5 or 0.8 or whatever. Okay? All right, good. Any other questions? I have I think 250 slides, so you guys can ask questions. Any other clinical relevant questions?
The second
Yeah.
question is, you advise to titrate the drugs that we use.
Yeah. How fast?
And, yes. How many time should I wait before I push
very
up?
Good. Very good.
Or
very good.
I go to another drug?
Yeah, good. So the question is obviously how long you should wait. So what do you guys do? You started, let us say you start dopamine. You started at 2 mics or 4 mics. Let us say 2 mics. Let us say you're cautious. You started at 2 mics. First of all, you need to make sure that it reaches the patient. And Gorm showed yesterday a study that might have shown that the drug reached the patient a little bit later than whatever. Anyway, first of all, it has to be in the patient. Under ideal circumstances, what you could do 2 things. One is that you understand how long your catheter is. It's 0.3 usually the cc is what it takes. I'm just making this up. Then you prime your tubing, and you push it like 0.2. And then you have a dilution that you can give it at a higher rate, so it reaches your patient within 5 minutes at least, and not within 5 hours, okay? So instead of 0.1 cc's per kilo per hour, nothing happens. And sometimes that's better, because kids recover without giving them anything. So anyway, having said that, because of the half-life, when you are sure that your drug, epinephrine, dopamine, going into the patient, or dobutamine, you don't need to wait more than maximum 5 minutes. Maximum 5 minutes. And when you actually titrate and come down with the dose, you don't need to wait more than probably the same thing, 2 to 5 minutes, because the half-life is so short. Now, many times when you titrate the drug down, the kid got better, and now you titrate the drug down, you find a critical dose. At 10 mics of dopamine or 0.5 of epinephrine, blood pressure is okay, peripheral is okay. And then at 8 mics of dopamine, you went down, everything tanks. That's the critical number of molecules you need to find the receptors, guys. That's what it is. So titrating down, I always suggest going slower. Going up, you can go in terms of dose-wise. So if it's dopamine 2, 4, 6, or 2.55, 7.5, 10, you can go faster. But when you titrate down from, let us say, 15, come down to 14, wait 5 minutes, come down to 13, and come down. And same thing with epinephrine. Dobutamine is trickier because, first of all, we usually jump by 5 based on animal studies, and also based on animal studies in pups, in dog pups, beyond 15 micrograms per kilogram per minute of dobutamine, you actually had this decreased diastolic function. Now, I don't know if really we can translate it to neonates. But if you go higher than 15 or so, make sure that you can do an echo as well, to make sure that you are not basically impeding the filling of the heart. If you have a dilated myocardium with a pooped out heart, dobutamine is the best inotrope we have. If you have a patient that has myocardial dysfunction and increased SVR, I would venture to say that Mirinone, appropriately titrated, is probably the better way to go with some whatever. In the CT ICUs now, they claim that with combination, and I don't know why, of lower to medium dose dopamine and Mirinone, survival has improved. And there is a study that they published. I have no clue why. We don't understand it. And there's no real study, so I cannot recommend it. But this is the rate of titration. I can recommend it because you won't harm the patient by this. Okay? Okay, guys. Thank you very much. I'm done. Okay, thank you.